My bread and butter and passion is HPV-related disease, or human papillomavirus. So I'm going to be talking a little bit about cervical cancer, and I want to give you a very brief overview of what my day-to-day is like treating patients with cervical cancer and some of the foundation that would be helpful to have to understand how my research fits into the clinical context and the global context as well. Have you heard in the media about cervical cancer screening, HPV testing, vaccination? Why are we still talking about it? I want to address that elephant in the room, why it's not eliminated. And I want to highlight two innovations that I cannot take credit for, but are coming our way that would be very exciting and for you to be aware of: HPV testing and the possibility of self-testing. And lastly, from my side, what I've learned in my research, I consider building relationships and innovation, and also some of the work I've been collaborating with the bioengineering department here at McGill. So I hope to give you an overview of how cervical cancer as a model, even if you don't end up doing anything cancer-related, nothing gynecologic related, I think this story is a great one to understand how health innovation can have an impact and the nuances of how we bring testing and technology into active practice. So my laboratory focuses on cervical cancer, as Jake mentioned, and I think of it as three different pillars. So one is biomarker discovery. We want to find more accurate, sensitive, and specific biomarkers that can tell us about a patient's risk of developing cervical precancerous cancer. The second on the right side is engineering and microfluidics technology. So in my background, I was an engineer before coming into medicine, and I've always wanted to bring that aspect back. So I've been privileged to bring the expertise of the engineering team into how we can think about bringing together the biomarkers and the engineering aspect together so that we can actually develop and deliver a point-of-care testing that can help patients. And finally, on the bottom, what matters most is the implementation of the technology. Technology doesn't mean anything if it can't get into the hands of those who actually need it. So I'll speak a little bit about the work we're doing with Indigenous health and marginalized populations. But those are really the three pillars I think about within my research program. So now for a crash course in cervical cancer. Almost all cases of cervical cancer are associated with the human papillomavirus, or HPV. And there are over 100 different strains of HPV virus. Some are oncogenic, meaning they cause cancer, and some are non-oncogenic, that causes genital warts. They are bothersome and can have morbidity, but they're not associated with cancer. The two that worry me the most are 16 and 18 because they cause the majority of cancers that I see in practice. So the evolution and how the disease progresses is very, very well established in cervical cancer. This is a zoom-in picture of what a cervical tissue might look like. And you start with the infected viral HPV particles. And the integration of the human papillomavirus particles get affected in the basal membrane of the cells. It proliferates, it causes mutations, it causes proliferation, and it progresses from what we call squamous intraepithelial lesion from low grade to high grade, or CIM 1, 2, and 3, to cervical cancer. So that's really all that you need to understand in terms of terminology and how the disease progresses. One thing I do want to highlight is this timeline from the left to the right. It takes about 10 to 15 years, generally speaking. This makes it an excellent model for screening. We have a window of opportunity to catch patients before it actually becomes cancer so that we can intervene. So that's why screening is so effective. So just to keep that concept in the back of your minds.
Okay.
what we know is that it's the persistent infection that causes the majority of cervical cancers. And its ability for the virus to persist and drive cell proliferation in the cervical transplantation zone, which I'll also show you pictures of. But the idea of persistence is very important because majority of HPV infections actually spontaneously regress. And as I said, of those that progress, there's a long period of latency, the 10 to 15 years I was mentioning. With the persistent infection, that's what I do a lot of counseling and education on with patients. 8 out of 10 adults who have ever been sexually active have the human papillomavirus. So a lot of what I do is destigmatize that. But why do we not see 8 out of 10 people have cervical cancer? Well, it's because a lot of them regress. So that is a very key message I try to bring to my patients in the clinic and helps us understand the disease and how we can intervene. So what happens when a patient has a HPV virus that we detect and we are worried there may be cellular changes and proliferation and we want to detect cancer or precancer? They come to me and I do an exam called colposcopy. On the left, you see it's a colposcope, which, for lack of a better description, is a magnifying glass. I can see a magnified view of the cervix. It's not very high-tech at all. And I place a speculum inside the vaginal canal and I visualize the cervix. On the left side, shows the biopsy forceps. If I see something on the cervix that looks suspicious to me, I take a biopsy and I establish a diagnosis with the help of my pathologist. This is what my Thursday mornings look like. You have a series of pictures of cervix from normal to L-cell, which is low-grade changes, and H-cell, which is high-grade squamous intraepithelial lesion. The picture on the far left is pre-cancer. That is where I want to see the patients. I want to catch them before they develop cancer, and I can actually treat those abnormal cells. How do I treat them? I do a leak procedure, which I will talk a little bit more about. So just to let you have an idea, the difference between cytology and histology, maybe very basic, but the terminology in cervix is a little bit confusing. Cytology is when we do a pap test and we just collect exfoliated cells. And the patients are obsessed about, do I have atypical cells, high-grade cells? What I need to explain to them is it's not very sensitive because we're looking at exfoliated, potentially dead cell that's been around for some time. We really need histology, tissue diagnosis to actually tell you what the next step is. So that's why they come to colposcopy with me and why a pap test in and of itself is not very sensitive. So talk about treating the high-grade lesions. What I do is in the office, I can remove the superficial layer of the cervix. And when I say superficial layer, it's about a centimeter of tissue. And it's with a heated wire and remove, and I send it to the pathologist. I'm hoping that there will be negative margins and that patient doesn't have precancer that comes back. Alternatively, we also do this in the operating room when we worry that there may be a deeper invasion. So this picture on the left side is what we call a cold knife colonization. We use a cold knife, and it looks like a cold when you have the final specification from the pathologist. So this is actually pretty morbid if you think about it, because I'm removing about 22 centimeters of a piece of cervix. And this disease affects women of reproductive age. So part of the complication that I'm worried about with a patient like that is if I repeatedly need to do these procedures, their risk of having a short cervix and delivering early if they get pregnant is quite high. So I would like to avoid these procedures, but this is how we treat precancer at the moment. When it gets more advanced, if they didn't get a pap test, didn't get an HPV test, and it actually progresses to invasive cancer, I'm not going to go into the details of the various treatments, but again, the highlight and message is that it can be quite lurid. So if it's only localized cancer, so we're talking about stage 1 cancer, I can do a surgery called radical hysterectomy. Hysterectomy is removing the uterus. Radicality refers to removing the tissue next to the cervix so that we have negative margins. Now, it doesn't look like a lot of tissue, but that technique and dissecting the ureter, the blood vessels involved in that can cause a lot of nerve damage, potential ureteric and bladder dysfunction. So it's not a benign surgery. There's a lot of consequences for the patient afterwards. If it becomes more advanced, let's say lymph nodes are involved and other pelvic structures are involved, we then consult our radiation oncologist. They do radiation, we add chemotherapy to it, and if there's metastatic disease, we have chemotherapy and immunotherapy to offer. But again, the survival at 5 years for advanced stage is somewhere in the 25 to 30%. So really, we want to do better, and we want to avoid seeing patients at this stage. One very sobering statistics, if you look at, you hear these talks about cancer statistics, and most of the time we're advancing with research, we're doing better. Cervix will actually be getting worse. The rate of increase in the number of cervical cancer cases is about in Canada, 3.7% per year. It's on the rise. It makes no sense if you think about it. We have the tools for screening, we have vaccine. Why is this happening? So again, my whole raison d'etre is to avoid putting patients through these treatments. So that's a crash course on cervical pre-cancer and cancer in less than 5 minutes. I spent 8 years in school for that. But questions? I'll take a pause. Yeah.
I'm slightly embarrassed to despite my ignorance about the disease, but is it always localized? Is the cancer normally localized at the tip, or can you anywhere?
It can be anywhere along the cervical canal. So the cervix does have a length. What I can see, the pictures that I see on the colposcopy, it's only the external. I would say 80% of lesions are visible by my exam. There's something called barrel cervix or adenocarcinoma that is deeper inside the canal. So those I can miss if I just look at the exam. So that's why we do imaging with ultrasound and MRI to see higher up if I am worried. But those are some of the squamous cell carcinoma are the most common type of cells in cervix that have cancer, but adenocarcinoma is more in the canal, and those can be missed. How we do. All right. So that's the disease process. So let's take a worldview of why is it on the rise. And this map is of the entire global incidence of cervical cancer, and it's the 4th most common female cancer. And we have over 500,000 new cases and over 300 deaths annually. Now, 90% of the deaths still occur in low-income and middle-income countries. And the primary reason for that is there's no organized screening program. The access to colposcopy, treatment, surgery, chemo, radiation, immunotherapy is much less. So if you look at where we live in Canada, the rates are reported to be less than 7 per 100,000 compared to parts of sub-Saharan Africa, it's more than 26. Having said that, though, there are pockets within our own backyard in northern Quebec, in immigrant populations, where our rates match that of sub-Saharan Africa. So that's why in Canada we still see the rise. So what is causing that and what's going on? As with any cancer, we think about how we can attack it by 3 different approaches. We have primary, secondary, and tertiary prevention. Primary prevention is vaccination. Secondary prevention is screening that I talked about and follow-up in colposcopy. Tertiary prevention is actually treating the cancer. I'm going to focus primarily on the secondary prevention today. I will talk briefly about the vaccine, but I want to focus on how we can do better when it comes to getting people screened and to see me in colposcopy at an earlier state. So one slide on vaccine. I know there's been a lot of vaccine hesitancy, and a lot of my work is actually education for both providers and patients on the efficacy and safety of the HPV Gardasil 9 vaccine. If I can make a plug, see me afterwards if you want a prescription for a Gardasil vaccine, as the indications have broadened. But all that to say, the New England Journal of Medicine publication, the only thing that you need to remember is in Sweden, where they have an organized vaccination program for the entire population, in their registry of over 1.6 million women between the ages of 10 to 30 years of age, they reported a cumulative incidence of cervical cancer of 47 per 100,000 among the vaccinated versus the unvaccinated was 94 of 100,000, so almost half. So this is very significant. I do want to dig into a little bit for the colors. So I don't need you to read the fine print, but you see the orange, blue, and green. So orange is the one that are unvaccinated, and as we follow them as they get older, the risk of having diagnosis of cervical cancer increases. Not surprising. In the blue, we see vaccination protects you from being diagnosed with cervical cancer. The blue shows those vaccinated between the ages of 17 to 30 years old. And the idea is there is value in vaccinating that group, but in that age group, the majority have had sexual relations and have contracted the HPV virus. So it's less efficacious. Compared to the bottom green, it's almost skimming the very bottom of the graph. We never see this in vaccine. Like, this is super effective. Not scientific word, but super effective. If you vaccinate someone before the age of 17, assuming that majority of people are not yet have their sexual debut, it almost completely eliminates their chance of getting cervical cancer. Like, no other intervention is this effective. So that's why we really do advise vaccination within a school-based program. But having said that, the indications of vaccination, again, up to age 45 and even higher in some instances, does provide some protection. So it's not all or nothing, but we know vaccine works. So that's all that you need to take away from the primary prevention idea. Secondary prevention. Okay, so I'm going to spend some time on this. I think most of you are familiar with the Pap test. And the history of the Pap test, it started in Greece. There was a doctor by the name of George Nicholas Papanikolaou, so that's why it's called a Pap test. He somehow convinced his wife in the 1950s, when there was no ethics, that she should invite her friends to parties at their place and let him swap the friends so that he can collect cells, so he can then look at the microscope and identify normal cells. But all that to say, those women who, I don't know how they consented to this, helped us find that you can detect abnormal cells when there's cervical cancer, and that is the basis of Pap test. It's very low tech. You look under your microscope, the cells look abnormal, have a colposcopy. Just that alone decreased the cervical cancer incidence over the last few decades by 80%. Huge. And again, why does it work? Remember that long latency. This disease has a window of opportunity where you can intervene. By all accounts, the science is there, the technique is there. It should be eliminated. So just with the Pap test, 80%. So we have to ask ourselves, okay, in this day and age in 2026, how can we improve on that? So the World Health Organization gave a mandate globally to have a concerted effort to have a vision where cervical cancer is eliminated. And their definition is 4 per 100,000. Remember how I said in Canada we're sitting about 7 and Sub-Saharan Africa is about 26? So 4 is kind of aggressive, but we can get there. And going back to the 3 pillars, we want the vaccine, we want the screening, we want the treatment. So focusing on the vaccine aspect, they want 70% of women who are screened with a high performance test by the age of 35. So this little one. And on the top, 90% of girls vaccinated by age of 15 with HPV vaccine. And this indication has brought into force. So I'm going to focus on the middle goal. How can we all contribute to the middle goal of having more people being screened? So when this came out, this was back in 2020, I think, and they were planning for 2030. So in 2020, I was in the middle of my, actually even earlier, I think 2019, I was in the middle of my fellowship when this document came out, and I got a text from my husband, Michael Allison, about this article, and I saw this, and I was like, oh, that's so nice. He's interested in my work, and he's sharing like newsworthy information with me. He's engaged in my research, cervical cancer. And then he texted me following this, like, pivot. Cervical cancer is not going to be a thing. You're going to be out of the job. I was like on a Saturday taking care of my HeLa cells at this point. And he sends me this meme from friends. If you haven't Googled and YouTubed it, please, I encourage you. There's a funny scene where they say pivot. Anywho, he was trying to convince me not to continue on cervical cancer. Obviously, we know who won, but it begs the question, why is cervical cancer still a problem? So a few things, and low sensitivity of a single pap test, the cytology that I was talking about, the high false negative. So if you can imagine, I'm collecting, again, dead exfoliated cells. There's a lot of technical challenges. You know, you're putting on a glass slide. How are you going to read it? There's inter-pathologist variability in reading it. There's also limited biomarker detection capabilities. P60 and Ki67 in the cancer world are widely known as proliferative markers. We do use those in cervix as well, but to actually clinically implement those IHCs on every single slide is costly and hasn't really been adopted. So we have some biomarkers, but we're not very sensitive in being able to detect them, and we are still relying on cytology. So how can we do better in terms of identifying biomarkers and detecting them in a more sensitive way? Lastly, and probably the biggest contributor, is accessibility. You saw the pictures. The coming to me in this weather for speculum exam that is cold, and for me to look up your vaginal canal, that is not an attractive proposition. So when I have no-shows in my clinic, I don't take it personally. But think about if you were an Indigenous woman who have to fly down, spend a whole week in Montreal to wait for a next flight back home. You're away from your kids and your family and what you're used to. You're waiting for just this one pap test, and then you have to fly home. Again, no one wants to do that. And that adds to the problem of accessibility, and that is why our Indigenous populations have the incidence of cervical cancer that is 3 to 4 times higher. Again, 27.7 in one series. Again, our data for Indigenous populations are sparse, but this mirrors what we saw in the initial global picture with Sub-Saharan Africa. So how can we do better? So we understand that there's a lot of health disparities faced by First Nations, Indigenous, and Métis people. There's a lot of historical and socioeconomic factors. I particularly like this drawing of why they have such barriers and reservations about reaching out for Western health medicine. Talking about their histories, their colonialism, their trauma, and how they feel when they walk through the doors. Are they welcome? All of those factors play in. And again, to reiterate, the geographical challenges also come. Like this, I won't be able to fly anybody to see me in my clinic at the Glen Hospital for a good 4-5 months until the weather gets better. So there's that delay. I highlight Shasta and Mississippi because those are the three populations that we have direct connections with at McGill University Health Center. We are the primary referral center for all Indigenous cancer health. So we see a lot of patients who are flying back and forth. And one of the initiatives that we have started is for gynecologists to actually go to those communities and reach out and actually offer services locally in their community. So again, reaching out and making those connections is one way to improve accessibility. The second part, I talked about the innovations. This is the first innovation, HPV testing. So you remember Pap test, you remember cytology. You understand that HPV drives most of majority of cervical cancer. So let's dive in. We have PrEP HPV, and Dr. Van Housen was the one who won a Nobel Prize for identifying that HPV is the causative agent for cervical cancer. So now we have a way with PCR to actually identify these viral particles. I won't go into all of the evidence, but just to say that globally, there are randomized controlled trials in majority of developed countries that have supported the effectiveness of primary HPV testing for cervical cancer so that we can replace the PAP with HPV. It's safe. And just want to highlight, in the Canadian context, we were actually one of the global leaders in this field, and we should be very proud. British Columbia, led by Dr. Ogilvie, looked at screening with HPV testing in the Canadian setting, and they found that it was equally effective and actually detected more cases of cervical precancer than traditional cytology. So we know it works. So now that we have the scientific evidence, rolling out and talking to the laboratory is the next step. I bring up this slide not to have you know all of the different types of HPV that it detects or the assay types, but just to highlight not all tests are the same, and I think you are all in a research mindset, and I want you to be critical when you're translating something to the clinical practice. There's going to be a lot of limiters, and we had to deal with that a lot. There is over 100 commercially available HPV tests. Just to let you know, Cobus and BD on Clarity, I have no shares at all, but those are the only two FDA and Health Canada approved tests. So all that to say, it's important to know which assay you are testing for, and the basis of it is PCR. So now we're able to offer patients 3 different types of screening. So HPV with cytology, so having both results. HPV alone with genotyping, meaning I'm looking for the most high-risk subtypes, so 16 to 18, or cytology alone. You may ask why we're still keeping cytology around. One, practically, there's still a transition and education that has to happen with clinicians and patients. But secondly, it's about choice. People want to be empowered. If they want a PAP test, they should be able to get one. So that's kind of the message we are sending. The most important thing is that you get tested. Yes, we prefer the HPV, but as long as you get some sort of test, even if cytology, that's great. And just to summarize, the primary HPV testing, the advantages are that it improves sensitivity for CIN3, which is the precancer I talked about. It increases detection by 50%. It also allows for self-collection and improved access. So think about, if you're looking for cells, that's really hard to collect on a self-sample and preserve it and send it to a cytopathologist. PCR, we're familiar with that. Everyone has done COVID swabs. It's the same exact concept. We know it's stable. People can do the self-testing. So it really opened the door for access. There are some disadvantages, lack of specificity. So there's a lot of HPV positive results that are actually not associated with significant disease that I do see, but part of it is improving our infrastructure and the skill base, and also provider and patient education, which is what I'm doing a lot of these days. Just to let you know what happens after a HPV test, you can still follow up with cytology, or you can look for the 16 and 18 genotypes. And again, just to reiterate, why do we care so much about 16 and 18? So not all HPV strains are the same. If you look at the red, this is HPV 16. The chances of developing CIN3 or worse, so precancer or cancer, is 17%, versus if you had some other strain, your risk is 3%. So again, helps me triage and think about the patient and what her risk is. In addition to that, I talked about biomarkers, and again, P16 and Ki-67 can be paired with both HPV test and with cytology to give us another data point to triage patients who are at higher risk. So if I have someone who stains both T16 and Ki-67 positive, that's a patient I really want to see very urgently at the colposcopy clinic. So I hope I've convinced you primary HPV testing is, the new technology that is evidence-based, which have genotype and P16 and Ki-67 IHC to support that and to explore additional biomarkers. But overall, that is the reason why you're hearing in the news that we're transitioning to primary HPV testing. The second innovation that's super exciting and not yet available in Quebec, but available in some places in Canada, and it is available in Netherlands and Australia, is self-testing. So I mentioned how it's a PCR-based assay, right? So what we are aiming for is that we can mail these brush or dry swabs to the patient's home. So you can collect the sample in the comfort of their own home with instruction, pamphlets, videos that they can find, and they can mail that result back in. We know that this HPV-based screening with a self-collection option opens the door for a more equitable approach to screening. And the evidence to support accuracy and comparability to a clinician-collected sample shows that for PCR-based assays is exactly the same. So when it is become available, and it's really a laboratory infrastructure situation right now, I want to be able to tell my patients, look, you coming in this weather to see me for a speculum exam versus you doing it at home is exactly the same. That provides a lot of reassurance. And we hope that this increases screening participation, particularly among the under-screened populations. So think about the Indigenous patients up north. They don't need to fly down. They can do the swab and it can be mailed to the lab, and we can get the results over phone and arrange follow-up. They have done a lot of studies on patient satisfaction and acceptability as well. There was some concerns, would patients really want to do this by themselves? Are they capable? Generally speaking, everyone is much happier not to have a speculum exam and have this exam at home instead. So again, they are taking the exfoliated cells, but from the cells we are extracting the HPV DNA. There's different brushes, and we show that those devices are, there's different types of collection devices, but overall the simple Copen swab that we're already using for other vaginal cultures work perfectly. So that is the evidence that support this. And this is the kit that is currently available in British Columbia, and we hope in the next year or two will be available in Quebec, where people can request it and have it mailed to them, and they can just mail the test back. And this is part of the plan, just to have some optimism in that, which is our health governing body, does support self-sampling, and they know that it should be one of the options that is available, and there's a lot of laboratory validation that is underway to allow for this. I'm going to pause there for questions. Any questions about HPV and self-testing? Yes?
Maybe someone else.
Yeah.
Are there any research that are about the HPV self-sampling versus in-office testing? So is the accuracy the same? Is it similar? Is there a large variation?
Yeah, so it's very similar. I didn't go into it, but it matters which type of testing. You know how I show you that table about all tests that are same? So this looks at signal amplification assays, and they ask that exact question. The office, me collecting it versus patient collecting it, there was a discrepancy. But with the PCR test, so the COBIS and the BDL clarity that I mentioned, the two lines, the blue and yellow on the top there, are exactly the same. So there has been validation. So a lot of my job outside of research right now is talking with the laboratories and talking with them about how we're going to do the lab validation for our own center, because it has to happen for each individual machine and each new center. That's what's taking the time for the implementation. But overall, what we're going to be offering is the PCR test, and I can show this data to patients and say it's exactly the same. So trust yourself and trust yourself swab. Yes.
I think there's a concern about the low specificity of the test to some extent, right? Then I'm just wondering if you could talk a little bit about what percentage of the patients or people in the population will test positive, and then what proportion of those would have eventually developed cancer,
Excellent question. So prevalence of HPV depends on the population, right? I would say in general terms in Montreal here, probably somewhere in the realm of 10 to 15%. If I handed out 100, there'll be about 10 to 15 that I get. It's a lot more sensitive, but it's not very specific. Like I said, a lot of the HPV viruses are transient. So the specificity has two clinical implications. One, my number of referrals and patients I need to see because the HPV test that is not going to end up likely being anything is much higher. But so there is that resource consideration. It can increase by about 25 to 50% based on modeling. We're still learning the real world data because we are probably the fourth or fifth province in Canada rolling this out, and we're learning from what the actual numbers and uptick, number of referrals is. So that's one clinical consideration. It's very real. It's how many patients can actually see. The second is patient anxiety. You're absolutely right. They're going to see me, they're going to find nothing, and they're totally freaked out. It's oh my gosh, I have HPV. What does this mean? We want to lessen that. So a lot of what I do in the clinic is kind of calm them down, reassure them. There are a lot of false. I think I can answer your question with some of the work that I'm doing because I am hoping to help improve the specificity by looking at biomarkers that can not replace but paired with HPV testing. But the future outlook, if I was to give this talk in 5 to 10 years, my hope is that with increased uptake of the vaccination, and if we screen patients who are HPV positive and we treat them, and the prevalence of HPV goes down, the specificity will overall improve. So I didn't bring the data here, but the modeling shows that there's going to be a transient increase of colposcopy referrals for about 5 years, and then it's going to go baseline, and then it's actually going to be less. So on a health system standpoint, it still makes economic and political sense to roll this out. But there's a lot of nuances in how we roll it out, and do we do a phase approach? Great question. Yeah.
So I want to know more about the type of HPV virus that it picks up on when you do a self-screening. Is it all encompassing and it's a yes, no, whether you have it or not? Or is it just picks up on maybe two? I think this is a detail that I kind of miss.
No, great question. So right now the results, the report that I get information on 16, 18, 45, and they group all the others. So there's a total of 14 strains. They can't be exhaustive, but there's 14 strains that they test.
With the self-screening?
With the self-screening and with the clinician collected. So it's the same PCR at the end of the day, but they're testing for 14. Now, practically, the idea is that the other 11 strains that I don't get specific details on, their risk is relatively low of having pre-cancer right now. So how we manage those patients is, let's not freak you out, let's not make you come for a colposcopy exam, but let's repeat the test in a year because your HPV can just become undetectable and be cleared. So I want to see the patients who have 16 and 18, which you saw 17% chance in the next 5 years they develop precancer cells. So that's a patient I worry about. So on the practical level, that's the kind of information I get right now. There are some assays that give you information on individual strains. They're more expensive. So at a public health standpoint, we have not adopted that, but they are available. Like I know that you can like go on Byron and like pay for self-testing actually. If you guys are curious and want to have $100 to spend, do this because it's kind of interesting. I was actually kind of disappointed. I did that. I ordered just out of curiosity. How does this work? I never got my result. I thought I was very disappointed. So I don't trust the guidance system per se. But all that to say, you can get information on these subtypes, but clinically is not as relevant because for all of them, I would wait for another year anyways.
Thank you.
Yes.
Hi. For the vaccination in your graph, you mentioned that vaccination under 17 ages, it drops the value, but then in the graph, it's cut at the age of 28. Did they use like follow-up or is it just stable after that?
I think they had, I think it was I want to say it's a 7-year follow-up. So I think it was at time of publication.
Because the other like two categories were like the graph went all the way to the end. So I wonder like would those develop then cancer above like 28 or no? Is it stable after that?
Very good question. Yes, it's stable after that because once you have the vaccination, your chances of contracting HPV is extremely low, and having it cause a problem is extremely low. But it's a good question. I haven't looked at the details on like if they just stopped follow-up or if like it was so low that it became not feasible.
Mm-hmm.
But generally speaking, we say that there is going to be my hope that because what I would see is of the adolescents who are getting school-based vaccination and therefore facing immunity as well at some point. Screening with HPV tests can be spaced out every 10 years, or you do it one time and then that's it, because the risk is so low.
Yeah, but I just look like scientifically looking at the graph because even at the blue one, it just started low, but then after 28, the rises is starting to go up. So like if we can see what happened to those like vaccinated under 17, it would be better to see the full graph and then the full trend.
But I think you also gotta need to put it into context. You're absolutely right. From a scientific point of view, it'll be interesting. But look at the y-axis. The first marker is 25. My elimination goal is 4. We'll never get to 0.
Mm-hmm.
There is going to be always some cervical cancer that is not HPV related, the weird and wonderful that I present at tumor board and that right case reports about. That's not the goal of the public health. That's not the goal of vaccination. And I tell patients that because that is the argument that, you're not going to catch the non-HPV cervical cancer. It's true, but from a public health standpoint, I'm already reaching, without the screening program, the elimination goal. But from a scientific standpoint, I totally agree.
From what I understand, when a Kaplan-Meier ends early, it means the model didn't have enough data to be able to provide a reliable estimate.
So it may be that.
There's probably just not enough subjects in the green one. That's certainly.
Thank you.
Is there any data about patient anxiety with deep turnaround time with self-testing? And how does that differ between testing versus self-testing turnaround time with mailing it in?
Great question. So I think it's unpublished data, and British Columbia is going to be the first ones to publish on this. In speaking with Lily Proctor, who is the cervical cancer lead of the province, their turnaround time for by the time they get the swab in the lab to getting the results, the turnaround time is a month. And they produce a report that is sent to the family doctor or mailed to the patient at that time. So it's about realistically 4 to 6 weeks, which really is so much better because psychology right now, practically speaking, what I experience here it can be up to 6 months. But yes, absolutely, patient anxiety waiting for the results is a very real concern. And actually, the HPV test, because we are not relying on cytopathologists to read, and the resource list of a PCR is just number of reagents, right? It's much easier to attain shorter wait times for results. So, great questions, yeah.
If the HPV test came back positive, is there a time after exposure, if you treat it with antivirals, that there is no risk of cancer? And I mean, if it's an early stage.
So, absolutely. So there are vaccine trials for established cervical cancer, but I didn't go into the data for this. But this is where the interest in a secondary use of the HPV test, I think it's to the point, if I understand the question correctly, because the idea is, how do I word this? I tell patients HPV exposure and me detecting HPV at one time point. I'm sitting in front of you right now and you have a positive HPV report. Chances of you having cancer still is very, very low. Okay? And it's only untreated, and those who have never had a test, those are the ones that I normally see in my cancer blood cancer. The idea of like the viral particle, what we actually know is that we want to. There's data now to support adult vaccination. That's why I was only half joking and I'm writing guys' prescriptions. Is exactly that. With the vaccine, even after exposure, your antibody titers go up and you have additional protection. And interestingly, when they study not in cervix but another HPV-associated cancer that I do research is anal cancer. And when they talk about vaccination, vaccination versus non-vaccination in adults, they actually say from natural exposure. So your antibody titers is different comparing men and women. And women actually don't. Women build a stronger immune response to natural exposure than men. So that isn't when the people tell me like, oh, I don't want to vaccinate my boys, it's a cancer for girls. That's kind of the evidence I use to say there is one herd immunity, but also your boy is going to get exposed to HPV and their natural immunity is not as good as girls for whatever reason. We don't know the biology behind that just yet, but that is also an argument I use to say we should have gender neutral vaccination.
No, good thing about IMS, right? Why can't they just look at the British Columbia data and adopt it? Why does it take them 2 years to do their own study and replicate and what's right them in there?
Oh, that's such a gut-wrenching question. I asked myself the same question. But just adopting the HPV has been a very laborious process. I don't necessarily, it's not the science, I think, that they're worried about. I think it's the resources and the financial cost because there is an upfront cost. It's a short-term thing.
Isn't so they get the political win and saying they're looking at it with the MTU term and saying, oh, still doesn't need these is a way out of the cut up.
There will. And then, as an aside, the political story here is in May 2022. I started back at McGill as an attending in July 2021. May 2022, the health minister said, "Oh yeah, HPV testing is ready to go," and I was like, "Huh? Like, where did this come from?" And only today, we are having HPV tests roll out at the MUHC in February 16th. So that's why I'm busy setting everything up. But yeah, the political and the news stories is not to be trusted. Sorry if I sound cynical, but that I think goes to the concept of that's why the implementation part of what I do fascinates me so much and why I feel so important. At heart, I'm an engineer, I'm a basic science researcher, but if I don't engage with the implementation aspect, like we'll get nowhere. So the science itself doesn't sell enough, sadly. I'm just worried of time. I love the interaction, but can
We still have 5 additional minutes. I think if you went on a bit longer, it'd be okay.
it'll be okay?
Yeah.
I won't be offended if anybody needs a fasting break or needs to go. I will give you the highlights. So one point I wanted to, and I think it's a nice segue, is what I've learned in the past 4 years is I love engineering, I love innovation, I love the concept of finding something new and finding a new way of doing things. One of the very humbling lessons I've learned in the process of doing all of this work is that building relationship in and of itself is an innovation. This is a group at the Indigenous Health Center of Urban Montreal. They're located at the Queen Elizabeth, just across the street from the Glen Hospital. But they have a setup where patients are able to be in a more comfortable environment at the Glen Hospital. And I have reached out to them and we've collaborated, and I'm now doing once a month, possibly going to increase to twice a month, clinic offering pap tests, colposcopy, and other women's health needs there so that I can meet them where they are. And with that relationship, I'm able to establish further connections with the communities up to north. You have to start somewhere, and tactically, of course, kind of urban is easier. But that in and of itself helped bring the HPV testing. I can tell them, hey, the Glen is going to have this new test. Can I talk to your patients about it? Can we set up the infrastructure for it? So key. This, I want to give a shout out to Yunin in the audience, my PhD student who did it in actually your global diploma course. We looked at a environmental scan of what are the barriers and what are the needs at each step of the way along the trajectory for Indigenous patients in cervical cancer. So all that to say, there's a lot of barriers, but we can overcome them with some thought. And again, it's all about building, for this particular situation, it's about building relationships. But I think if you think deeply enough about your own research and your own interest, I think relationships is at the core of actually getting that science into the hands of those who need it. So, and then this is a bunch of engineering things that I'm not going to go into, but all that to say, this is my pie in the sky. I am hoping that I can have this microfluidic device where I can put a droplet of the self-test liquid. I can process it, and it can be somewhat like a pregnancy test where in the clinic, after 30 minutes, I can get a digital readout, and it can tell me if there's P16, Ki67, HPV 16, 18, and I can tell the patient then and there, you have HPV 16, let's bring you to my colposcopy clinic next door, and let's get everything done all in the same day. So again, decreasing more visits, improving access. That is my pie in the sky, and the fluorescent imaging system is actually not a difficult thing to access if you're thinking about the low and middle income settings, because a lot of them actually have phones with cameras and they're able to do fluorescence. So that's kind of my plan in the sky for my FIQS streamer too. So with that, a few key messages. It's not enough to have the technology. We need to get into those who need it most. Start to see building relationship as part of the innovation journey in your work. And lastly, find a life partner who will challenge you, but always know that at the end, you're right, you're on the right track. Only listen to them partway. And this is my email address. Please feel free to contact.
Your talk was really informative, and it's going to be thanking you.